Rachel, we've been kind of going back and forth here a little bit, talking about throwing out a lot of numbers here. Can you talk a little bit about the sensitivity of these assays and how we interpret some of those results?
Right, so as Ryan mentioned, in the US, we predominantly rely on flow cytometry for our MRD assessment. We use a threshold of 0.01% or 10 to the minus 4 for the sensitivity of that assay is pretty well established. PCR, I believe, is about the same. Next-gen sequencing that Ryan discussed, the DNA-based method, it reports down to 10 to the minus 6th, but I know it can be more sensitive than that. I think that raises the question of how sensitive is too sensitive. I know when I speak with all of my patients at the end of induction, I said, even though by the metrics we use to measure your disease, we don't see it, we know it's there because it will come back if we stop your treatment now. So if we know it's there, how much of it do we need to detect to be prognostic, I think is an important question. And we're actually studying the incorporation of this extremely sensitive modality in our upfront BALL trial right now. We're taking our flow negative patients and we're testing them by high throughput sequencing MRD. There is some literature to suggest patients who are at the end of induction MRD negative by both flow and MRD have an incredibly excellent outcome in the 98% event-free survival range in our population.
Jay, I wanted to ask you, sometimes, certainly in my practice, I get into these situations where the patient is persistently MRD positive after multiple cycles of therapy. Perhaps I've switched to blinatumomab, and now they're still MRD positive. How much do you keep treating them to try to get to MRD negativity, or do you say we're not going to get there and we need to think about moving toward a transplant sooner rather than later?
Yeah, I think that's the challenging situation there too. So I think after the one or two, after blinatumomab is typically kind of what we do for the B-cell ALL who are MRD positive after one or two cycles, and if they're still MRD positive, I think that's really the decision-making time point to decide this is as best as we're going to get, and then because we don't really have there may be some other therapies, but does it make sense to give some multi-agent chemotherapy or some other clinical trials for these to get into MRD negativity, which there is no guarantee they will be MRD negative. They may actually relapse during that time, and then we may also lose the window of opportunity to go to transplant in relatively stable, kind of controlled disease setting. So it is, I don't think there's any straightforward, but for me, kind of after kind of one or two kind of the month of a treatment, if they're then MRD negative, it's certainly not changing, then those are the patients that will just take the transplant. And also it may depend on the level of MRD there too. So I think if it's certainly a low level, less than 0.01% or 0.1%, then you may consider those kind of the relatively lower level of MRD to go to transplant. But if a high level of MRD, although again I may try a little bit more, but that all depends on the condition of the patients, their previous kind of the lines of a therapy, what additional therapeutic tools that we have, what's a reasonable chance that I'm going to achieve that MRD negativity, because again there is the chance we'll be taking either way. So I think it's really just kind of the comfort level, the data of kind of what other tools that we have, but it certainly kind of prevents a challenge.
Yeah. Rachel, you alluded to this a little bit earlier, but tell us a little bit about kind of that patient that's persistently MRD positive, how you approach that as a pediatrician.
Yeah, that is one of our most challenging scenarios as well, for sure. It's fortunately for us a bit more rare on the pediatric side than the adult side. But we will use every available option to try to get them to MRD negative status because we know that dramatically impacts your post-transplant outcome. There's a nice study by Mike Pulsifer looking at even if you're MRD positive by next-gen sequencing, you still have a much inferior post-transplant outcome, much higher risk of relapse after transplant. And so we'll even employ CAR-T, blina certainly, inotuzumab, other agents to really try to get them into MRD negative status before sending them to transplant because their chances are much greater of being cured if we can get them to that state.
Yeah. I think one of the challenges though is really, at least in my opinion, transplant is really probably the only thing that's going to be able to realistically give that patient a chance of long-term remission. We always have to be mindful of the fact that these therapies we're giving to try to achieve that level, they may not work, may make them sicker, may preclude them from moving ahead with the therapy that we're ultimately trying to get them to. So it's a particularly challenging situation, and I think it's even more challenging in older patients where we can't necessarily assume that myeloablative conditioning is going to be able to mop up what's there. If you're talking about a patient who's maybe in their 60s or has a lot of medical comorbidities where their only realistic chance of a transplant is with non-ablative or reduced intensity conditioning, going into a transplant like that with persistent MRD is almost certainly not going to work. So that's another really challenging situation. So hopefully there's some novel approach to the transplant that can be offered or something like that.